We're ready.
All right, let's power on. Home stretch. So let's talk about aneurysm treatment. So first and foremost, if an aneurysm ruptures, it needs to be secured. An unsecured aneurysm is just a ticking time bomb waiting to rebleed. Just because your patient's aneurysm has popped once doesn't mean it cannot pop again. And typically, if it pops again, it's bad, bad news. So intervention comes in three-ish flavors: clipping, coiling, and stenting. Stenting involves placing a stent to occlude to block off flow from the aneurysm. Coiling involves the use of putting these small metal coils, which is pictured in this top picture here, and to fill up the aneurysm, and it will clot off. You can also do a stent-assisted coiling as well, so you can coil and stent. It's important that patients who are stented do take their antiplatelet drugs afterwards, or else that stent can and most definitely will occlude. And they could have a very, very bad outcome. Ooh, clip is what you see here on the bottom, and this is where you place a clip over the neck of the aneurysm, and this can be done in a ruptured and unruptured aneurysm, but this does involve opening the cranium via craniotomy and placing a clip. We're seeing more and more endovascular treatment as opposed to open clipping. So that's become one of the trends. Another form, and this you'll see this term used a little interchangeably. It's just embolization. Embolization can be accomplished using coils and stents, but also can be used using injection or glue type particles such as onyx. What you're seeing here is an angio of an AVM, and you can see all this dark clouded contrast going through this big tangle of blood vessels. And you can see over in this other one that it's still present, but there's nothing flowing through it. So they've been able to successfully embolize this AVM. Now, embolization can happen via open surgical approach as well, where um, the surgeon will go in and begin to cauterize feeding vessels to a large bundle of vessels. So there's multiple ways in which this can be accomplished. So jumping down to the medications, and we talked a little bit about these already, but in hemorrhagic strokes, it says anti-seizure medicines. I will tell you this, anti-seizure medications are not indicated in all hemorrhagic strokes. They may do it prophylactically for a couple days, but always, always consider that less is more. The less intervention you need, the better it is for the patient. Again, it says no anticoagulants. This is oops. That's not necessarily true. We want to initiate VTE prophylaxis on this patients. We typically within 24 hours, but it does depend on several factors. And subarachnoid hemorrhages, we talked a little bit about nimodipine. Now remember, pine drugs are calcium channel blockers, and this drug serves to reduce vasospasm potential in these patients. As a note, it also can reduce blood pressure, but this is going to be on a patient-to-patient basis. If your patient does respond and become very hypotensive, that's when we might split up the dose from a 60 milligrams every 4 hours to a 20 milligrams every 2. This can also cause very bad diarrhea because nimodipine is an elixir. Um, you get daily TCDs we mentioned, and that's assessed for presence of vasospasm. Typically, vasospasm is something that we can watch occur, meaning that we watch their flow velocities in their brain go up and up and up, which is good because we can see it coming if it's going to and prepare ahead of time. But that being said, it can occur. It can also occur symptomatically very suddenly. This mentions Triple H therapy. Triple H therapy is not something that we do anymore. And then, oops, if the patient does incur a symptomatic spasm, It says here that angioplasty or stent if this Triple H therapy is not effective, but that's not typically the case. What we tend to do is one, we aim for euvolemia. We may end up pressing them a little bit to try and get their blood pressure up. But often, if it's severe enough, we'll send them straight down to IR, and IR will go in, assess the situation. They may inject some intra-arterial nicardipine to help open that vessel up. And every once in a blue moon, they'll do an angioplasty, but I'd say I've seen maybe like one or two in the last few years. So I'm going to skip the case study. Let's talk a little bit about headaches. So headaches can be a problem. It says they're a symptom and not a disease, which is, I don't know, it's neither here nor there. People can suffer from chronic migraines, and that sucks. I mean, I think I might call it a disease, but maybe that's just me being a contrarian. So headaches can happen due to stimulation, tension, traction, pressure, pain, tumors, anything psychogenic. And it typically involves a dilation of these cerebral blood vessels, which can also happen secondary to drugs. Space-occupying tumors, increased ICP, hemorrhage in the cranium, and a whole slew of factors. Evaluation by providers is often limited in today's healthcare, given current regulations by insurance companies. It's very unfortunate, but from time to time you see patients come in with a headache, and they're like, "Oh, you're having a migraine. Let's give you some Benadryl and some other meds to try and ease that out." Then they get sent home, and they come back later because they've had a large stroke or some other catastrophic neuro event. Unfortunately, we typically don't do CTs or MRIs straight away for headaches unless there's some other fortifying clinical data that's going to give us a reason to check. But conversely, in severe migraines or cluster headaches, you can see patients develop certain stroke-like symptoms, focal deficits, visual deficits, sensory changes. So that may give cause enough to get a head CT just to make sure that nothing else is going on, as well as baseline labs. So here's a CT in which you can see on the left you have a ring enhancing lesion. So on the right you have a CT, on the left you're dealing with an MRI. Now if you start on the right, the scan that's on the right, which I don't think that these are the same patient, because their brains are shaped differently. On the right side, you don't really see a lot going on. One thing that I will note, which is a little strange, is when you look at the top here, which is the frontal part, you can see the frontal sinuses, but you can also see some artifact from what typically would be metal. And I don't really know why a patient would have metal on their forehead. But when you're analyzing the actual brain itself, there's nothing really overt going on. But one thing I do notice is in this left lower area, we see this hyperdense zone and what appears to be some fluid within the tissue, which makes me wonder if this is a patient who's undergone some form of drain placement, and then maybe this shining is from staples. Maybe that could be somewhere in the head, and this could be something like a VP shunt or a post-surgical drain. It's hard to tell. But jumping back to the MRI on the left, what you're going to see here in this left parietal lobe is a ring enhancing, meaning that it has a ring area, and it's hard to say what this is without knowing what the sequence is, but you can see that this person has a mass lesion in their head. So under clinical manifestations of headache, these are some for cluster headaches, tension headaches, and migraines. Um, it's honestly, in real clinical practice, very difficult to characterize these specifically. Now, the one thing I will point to for cluster headaches is they tend to be unilateral, all caps, unilateral. Um, and then tension headaches tend to be bilateral. And tension headaches also can be relieved without pharmacologic measures. Um, and migraines are a whole other ball of wax. Um, People who suffer chronic migraines, it can be a real tough situation where, they can suffer from these for 2 or 3 days at a time, and they can also, have maybe one day of respite and go back into a migraine cycle. Uh, One thing to note is that certain medications for migraines can lower your seizure threshold, in which case we have seen cases of patients we have seen patient cases that have presented with status epilepticus secondary to migraine medication use. Patients who suffer from chronic migraines often experience an aura. They typically know when this is going to occur. I've only experienced a handful of migraines in my life. And I remember the first one that I experienced, I had a specific visual field deficit, which was kind of scary at first. I was like, what is going on? And then what proceeded was 3 days of awfulness. I'm not going to spend a lot of time on headaches because we're short on time. I will say this and draw your attention to this. If you hear the patient say, "This is the worst headache of my life," they need a scan. You should definitely take into consideration if the patient has a history of migraines. But these words are often spoken by people who have subarachnoid hemorrhages, and it's kind of interesting because I always was told this in school and learned this in life, but I always thought like, oh, there's no way, that specifically is what's going to happen. I will tell you, like 8 out of 10 subarachnoid patients come in and say, I have the worst headache of my life. Very common. When you're assessing your headache, you want to assess location, quality, aching, stabbing, throbbing, radiating. How often? When does it occur? Does it occur at a certain time of day? How long does it last? What makes it better? What makes it worse? And this is a general assessment that you can use for just about any type of pain. And of course, taking a full health history and a medication history. So what are they on? What are they currently taking? Migraine teaching, avoiding triggering substances, therapy, stress management, things that most of these patients already know. People who have chronic migraines are often managed by a physician, and they're often pretty well acquainted with what their symptoms are, but always helps to reinforce any education. Medications for headache, acetaminophen and NSAIDs. It's good first-line therapy, but it can be troublesome in the long term. Some people can get into habits of taking, Tylenol and ibuprofen like candy, and that can be very damaging to your liver and kidneys. Beta blockers may be used, propranolol specifically for migraine prevention. It can also be used for anxiety, among a few other things, including heart issues. So that's actually the end of the slides. Mark, do you want the last 20 minutes?
I can't see I can do much with 20 minutes.
Well, all right. Does anyone have any questions? Now's your chance. Now's your chance. Study guide. Yeah, I have 13 pages that I'm going to send out either tonight or tomorrow, and these are all my notes. Now, I will say this. I'm going to send it to you, so you're going to have a lot more information than what you see on these slides. But on the next test, on the next exam, there's going to be what, Mark, 5 neuro questions?
5, yes.
Yeah, so I'll give you all that information, and then when I make those 5 questions, I will think of some way to not tell you exactly what they are, but give you some guide. I can tell you this: there will not be any trickery on my part. Everything will be very straightforward. What's the deal with the quiz? I know we had discussed putting the quiz in Canvas. I did not have a chance to come up with quiz questions, but if they're going to be, when they're in Canvas, is it a self-paced thing, Mark?
What is that? Self-paced?
Yeah.
No, when you open up the assignment, it'll give you the option of creating a quiz.
Okay, but they can do that on their own time.
If you want to do that for Neuros for today, that'd be good.
Yes.
I plan on doing it a couple of times. We'll just have them take it online, right on Canvas.
Okay, so we'll just do that and have it in there.
I'm still trying to figure out how we're going to do this with everybody in 30 different places, but
yeah,
okay, well, 29 different places.
We're gonna have your Scouts honor.
You have my Scouts honor.
Uh-huh.
I'll make 2 quizzes, and I promise none of the questions on the exam will be tricky.
Mm-hmm. So we need to take the neuro quiz today. Chelsea, easy there. So we need to take the neuro quiz today. I'm not going to guarantee that it's going to be up today, but I'm going to try my best to get it out in the next 1 to 2 days if Canvas will comply. Canvas has been my arch enemy for the last week. So, all right, Mark, I'm done. I'm not going to do any case studies right now. So if you have anything you want to add. If not,
Anybody have any general questions?
I see a
chatty people. What are we saying?
Mark, in your email,
Wednesday the 11th open for skills lab. No, that's for the 6 people that missed skills lab.
Mm-hmm.
We're going to have a makeup skills lab, pardon me, for those people tomorrow at 2 o'clock. If they don't make it, they don't miss, if they don't get that skills section done, no pressure. But if you don't pass skills, you don't pass the course. You don't pass the course, you don't move on to the next quarter.
No pressure.
So, okay, there might be a little pressure there. Just do it.
All right, if nothing else, I'm going to sign off for today. All right.
I'm putting out a study guide for the final exam and exam 5. That is the plan.
Awesome. Thank you.
All right.
Yeah. I'm looking through the rest of these. Gotcha. Thank you. One way.
I think you got it.
All right. Any other general questions?
Yeah, Mark, do we have skills lab next week?
We still have skills lab next week. We're going to do NG tubes and eyes and ears.
Okay.
Katie.
That'll be the last one.
Katie says, feeling overwhelmed with all this neuro A&P. Any advice on study strategies? Don't worry too much about A&P. I think we're going to do, like, as far as question goes, we're going to talk about stroke. We're going to talk about subarach. We're going to talk about ICH. And if there is something specific to A&P, I will mention it when I put out a study guide.
All right. Thank you.
All right.
Thanks, everybody.
You're welcome. Thank you.